Hey guys, my name is Samantha Romano. I'm one of the second-year emergency medicine residents at UT, and today I'll be talking to you guys about airway positioning for intubation. So first things first, why do we care? Reasons we care about this, of course, are to optimize yourself so you're successful in your intubations. It increases the rate of your first attempt, and all of these things together improve patient outcome. Okay, so before you position the patient to intubate them, you need to make the decision on if you are going to intubate. Certain things that you need to consider before deciding to intubate is, will this patient be a difficult intubation? There are two acronyms that we can use to evaluate this. The first one being LEMON and the second one being BFAST. I think for most of you guys out in the field, BFAST may be more relatable as it stands for blood, MSS, facial trauma, airway edema, spinal immobilization, or large tongue. If any of these are abnormal or present, you may want to consider an alternative airway. Same with LEMON, it just stands for look externally, evaluate the 3-3-2 rule, Mallampati score, obstruction, and neck mobility. The 3-3-2 rule is the photo in the top right. You can see that you basically use the widths of your fingers to determine the space of the patient and if they will be a difficult airway. You can see it's 3 finger widths for the space between their mouth, 3 for their chin, which is the hyoid mental distance, and then 2 for the hyoid thyroid cartilage. The Mallampati score is the second image, more closer to the bottom right. Class 1 being the best view where you can visualize the entire soft palate. 3 and 4, this is a kind of a terrible photo because they look similar, but the difference between class 3 and class 4 is class 3 should still be able to see the base of the uvula, whereas class 4 you can't see any of the soft palate. If any of these are standing out to you, then you should kind of proceed with caution. Consider, should you just keep bagging them till you get to the hospital? Will they need a supraglottic airway or an LMA? Or if they have extensive facial trauma and airway edema, will you need to do a crike? So once you determine you're going to proceed with intubation, another acronym we like to use to ensure a successful intubation is SOAP-ME. Specifically, this lecture will focus on the P part of SOAP for positioning, but I did want to add that, if you are going to intubate, we recommend you do it in the most optimal location, which for you guys out in the field would be in the unit, if possible. The reason for this being that you would have easier access to your supplies, better lighting. Should you need to revert to a different airway method, you'll have the kits available nearby for like a crike or an LMA. So I just wanted to touch on some of the letters in the SOAP-ME acronym. For S for suctioning, just having your suction accessible under the cot. If they're vomiting or bleeding, having double suction set up if possible. And then for E for equipment or end tidal, having a bougie nearby, or the cardiac monitor kind of in your view so you're aware of the patient's O2 saturations. And then how we like to practice in the emergency department as well is to have multiple backup plans. So, like different size ET tube available or different size Mac or Miller blade should your first choice not be appropriate. So moving on to the positioning part of the lecture. When you start to intubate, you want to consider 3 airway axes. And the 3 axes that you want to think about are the OA or oral axis, which is a vertical axis extending from the patient's mouth to the bed. The laryngeal axis, which you can see is they're midline to the patient's neck and parallel to the bed. And then the third axis is the pharyngeal axis, which extends from the end of the laryngeal axis up to the angle of the patient's eye. The 3 axes together, as you can see, creates like a right angle triangle. In order to successfully intubate someone, the goal is to align the pharyngeal and laryngeal axis, and we're going to talk about how we do this. So how we get the laryngeal and pharyngeal axis aligned is to utilize what we call a sniffing position or ramping position. And there are multiple ways you can do this. Some people use towels or blankets. Some people use the head of the gurney or cot to kind of elevate the patient's upper back and extend their head. Some people use their right hand if they're holding the laryngoscope with their left to kind of lift the patient's back of their head up and move as needed. As you can see in this photo, they've done a really good job of ramping or elevating the patient's head with blankets and a pillow. Another way to make sure that the axes are aligned is to look at the patient's ear and make sure that it's aligned with their sternal notch. This is ensuring that they're in the sniffing or ramping position. In obese patients, the ramping position is actually very important to think about. Because they have a short neck and a lot of external forces on their chest, you want to consider kind of dropping the head a bit for them last minute just to take off that weight on their chest. Alternatively, if you don't have blankets or pillows, if you have an extra set of hands, you could use someone else's hand to put behind the patient's head. That's another cool trick that you could do is if you have a pressure bag for fluids, you could inflate that all the way and put that underneath the patient's upper back or lower neck to ramp them up that way as well. You can see here there's another hand on top of the patient's neck. Sometimes some patients have very anterior airways and they require a little bit of what we call Craig pressure to kind of drop their airway into view. And I like this photo because it's just a summary of everything we've talked about. Here, this patient is in the sniffing position. You can see that their upper back and head are elevated using a towel and that their ear is horizontally aligned with their sternal notch, suprasternal notch right there. This photo also shows that you can see their face is horizontally aligned with that bed and towel. Once you've positioned the patient, you're now looking at this view where you're in their airway. Ideally, you'd like to get the photo in the top left, which is a grade 1 view showing their epiglottis and vocal cords. If you're seeing the grade 3 or grade 4 view, this is where you want to consider using a bougie or possibly trying anterior Craig pressure. Now that we've successfully positioned the adult patient, I did want to talk to you guys about pediatric patients. Infants and peds kids have larger heads or more prominent occipits naturally. Because of this, when they're laying supine or on their backs, their head is slightly more flexed than an adult, and this can compress their upper airway. Like adults, the position to optimize intubation for peds is to have that ear aligned with their sternal notch, and I'm going to talk to you guys about a stepwise approach to kind of meet those markers. This is just a depiction that shows the compression of the upper airway with the pediatric head flexion. So, other markers to look for successful pediatric positioning. I mentioned previously that the ear should be horizontal with the sternal notch, but 2 other markers are that their chin or glabella should be horizontal to the bed, and then that their neck should be wide or open. This is the photo here showing the infant sniffing position, which, as I mentioned previously, has the 3 markers. The first one being that their chin is horizontally aligned, their neck is wide and open, and then 3, their ear is aligned with that sternal notch. The stepwise approach that you should be taking to intubate a pediatric patient is head extension, shoulder roll, or adding a headrest and pillow. Specifically in infants, I would utilize these steps specifically in the order that they're written. The reason for this being that by simply extending their head, you may meet the markers required to put them in that sniffing position. In older pediatric patients, they're more similar to adults, and you may get away with just adding the headrest or pillow. And I'll show you some photos in the next slide which kind of explain this better. As you can see in the photo on the left, by just simply extending the pediatric patient's head back, he's meeting the 3 markers of the sniffing position. His chin or glabella are aligned with the bed horizontally, his neck is open and wide, and his ear is in line with the sternal notch horizontally. Whereas alternatively with the photos on the right, you can see that just the shoulder roll alone in the top photo do not meet the markers. His neck is wide and open, but his chin and ear are not horizontally aligned with the sternal notch or the bed. You can see then by adding a headrest after the shoulder roll and extending that pediatric patient's head back, he is now meeting the 3 markers. And that is all that I have for you guys today. Hopefully these tips will help next time you intubate out in the field. Thank you for taking the time to listen. If you have any questions, feel free to reach out.